Assalamu alaikum, respected viewers and my dear students. I am Dr. Farhana Islam, Associate Professor, Gynae and Obstetric Department, Akij Medical College, Khulna. Now, today I start the subject preeclampsia. Preeclampsia is a severely dangerous situation and dangerous complication for maternal and fetus. What is preeclampsia? Define and definition of preeclampsia. It is a new onset of hypertension and proteinuria after 20 weeks of gestation in a previously normotensive woman. Criteria for diagnosis of the preeclampsia. There is systolic blood pressure should be more than 140 mm of mercury or diastolic blood pressure more than 90 mm of mercury. And there is proteinuria, that means urinary protein, more than 0.3 gram in 24-hour urine specimen. We also classify that preeclampsia as a classic trait. P means proteinuria, R means rise blood pressure, and E means edema. Proteinuria can be explained that it is more than 300 milligram protein in 24-hour urine sample. And alternatively, we can also define that proteinuria is diagnosed based on a protein and creatinine ratio, which will be more than or equal to 0.3, or a depistic reading more than 1 plus. An absence of proteinuria on less accurate test like urine depistic test or urine analysis does not rule out in preeclampsia. Now it is proteinuria. Now it is rising blood pressure. R means rising blood pressure. High blood pressure may develop slowly, but more commonly it will occur suddenly. That means sudden onset of high blood pressure. Blood pressure that is more than 140 over 90 mm of mercury and should be documented on 2 testing and 2 occasions should be measured at least 4 hours apart, and which should be more than 140 over 90 mm of mercury. That is explain rising blood pressure. And now P, R and E. E means edema. Edema which should be measured by sudden weight gain. Sudden weight gain and swelling of the body, particularly in the face and hands and feet. More common in beating edema, which is beating edema and should be measured by press over the medial malleolus or over the lower part of the shin of the tibia, and there is an unusual swelling and particularly on the hand, feet and face, and there is an indentation on pressure on it. That means preeclampsia, there is a classic trait. P means proteinuria, R means rising blood pressure and E means edema. Now we should going for risk factor. Who are more at risk for developing preeclampsia? High risk group and there is low moderate risk group. On high risk group, patient may be on autoimmune disease, having autoimmune disease like systemic lupus erythematosus or antiphospholipid syndromes. And there is a chronic, if the patient has a chronic hypertensive, in pregnancy there is a chance of chronic hypertension with superimposed preeclampsia. And if a patient has diabetic mellitus, both type 1 and type 2, more chance of risk of preeclampsia. And if patient having history of preeclampsia in previous pregnancy, there is a double chance of preeclampsia in present pregnancy. And if patient has multifetal gestation like multiple pregnancy or triplet, there is a chance of preeclampsia. And if patient has a renal disease, chronic renal disease, there is a chance of chronic hypertension, and in case of pregnancy, there is a chance of superimposed preeclampsia. These group are on high risk group for preeclampsia, and moderate risk group are age, if there is a patient age more than 35 years or more than that, and black races or low socioeconomic status. Patient have a family history of preeclampsia. Family history of preeclampsia means if her mother or sister having preeclampsia, history of preeclampsia, and if there is a patient have an history of low birth weight infant, there is a history of adverse pregnancy outcome, or she has a history of prolonged subfertility, there is an interval between pregnancy 10 years or more, and now patient has an obese, like body mass index more than 30 kg or more, and patient nulliparous. Those are moderate risk group for preeclampsia. Now, how can we diagnose preeclampsia? We already know that there is an triad. Pre means elevated blood pressure, edema, and proteinuria. So there is an elevated blood pressure more than 140 over 90 millimeter of mercury, which should be measured at least 2 occasions and 4 hours apart, and pregnancy will be more than 20 weeks of gestation, and with proteinuria, which should be measured that in 24 hours urine sample, protein should be more than 300 milligram, or protein and creatinine ratio should be more than 0.3, or depistic test more than 1+. And there is an edema which should be measured by serial examination of the body weight. There is a sudden weight gain, increased sudden weight gain, and there is a pitting edema on shin or over the medium malleolus and indentation. There may be other feature, like patient may present with other feature like sleeplessness, or there may be headache, severe headache, or there may be oliguria, or may present with epigastric pain, or there may be blurring of vision, maybe restlessness and respiratory distress. Those are the feature of impending eclampsia. Patient may present with severe preeclampsia with impending sign of eclampsia. When preeclampsia complicated with convulsion, then we called eclampsia. Now, what are the pathophysiology of preeclampsia? There is two theory. First theory is abnormal placentation, and second theory is endothelial injury. Endothelial injury means endothelial abnormalities, and abnormal placentation, there in normal pregnancy. In normal pregnancy and after 20 weeks of gestation, or there will be in spiral artery. We know that spiral artery lies perpendicular from decidua and up to the myometrium, and when placentation occur, there is trophoblastic invasion occur within the spiral artery. At first within the decidua, and in second peak, there after 20 weeks there is second peak in which there is an trophoblastic invasion occur up to the myometrium, so that there is a vasodilatation and more blood can accumulate within it. But in case of preeclampsia, myometrial invasion of the trophoblastic cell does not occur, so that there is a vasoconstriction and not so more than blood cannot accommodate within it, so that there is a placentation is abnormality and chronic placental insufficiency occur, so that there is a chance of intrauterine growth retardation. That is abnormal placentation. And second is endothelial dysfunction. we know that in pregnancy, vasodilator agent should be increased in number in case of pregnancy, so that more blood should accommodate vasodilatation and more blood accommodate within it. But in case of preeclampsia, this vasodilator agent is decreasing in amount and vasoconstrictor agent are more. That means vasodilator agent like nitric oxide or prostaglandin I2, prostacyclin, those are reduced, and although alternatively there is rise in thromboxane A or prostaglandin F2 alpha, those are vasoconstrictor agent, and there is an alteration between them, so that there is all time there is a vasoconstrictor effect over the vessels, and together there are vessels are endothelial vessels are more sensitive to the vasopressor agent in case of preeclampsia, so that there is an endothelial dysfunction, so that there is a vasoconstrictor effect over that, and so that there is a rise of blood pressure, peripheral vascular resistance increasing, and pressure becomes rise. And those are pathophysiology or theory of the preeclampsia. Today's class should be ending now. On next class, we should discuss about further investigation and management of the preeclampsia. Thank you all.